Owen Tripp here, and Owen is a master in scaling data and making sense of it. And particularly with his first startup with Reputation.com, and now with Grand Rounds. So I want to start with, as I mentioned earlier in my opening talks, a lot of us in healthcare start because we've experienced something personal. And with Grand Rounds, it was somewhat similar with your founder, who had to get, was it a bone marrow transplant for his son?
Yeah.
So talk about that. That was 5 or 6 years ago. Talk about how you came up with this idea together.
Sure. Any Stanford med people in the audience? Before I say that? Okay, good. So my co-founder is Dr. Rusty Hoffman. He's the chief of interventional radiology at Stanford. Like many people who practice at academic medical centers, he is an expert in a very narrow thing for which a lot of people come from around the world to talk to him. And his thing is DVT, blood clots that form in the veins, especially in your legs. And if you have chronically occluded veins and DVTs, there's no better guy in the world than Dr. Hoffman to remove them in a non-invasive way. The interesting thing was that when his son, who's now about 12, but this happened when he was 8, when his son developed a very scary condition called aplastic anemia, the resources for Dr. Hoffman lay beyond the walls of Stanford. And I'll keep the story short, but basically the likelihood that this boy would survive given the initial diagnosis and the lack of a sibling match in the family was incredibly low. And Dr. Hoffman was a match, but parent-to-child donation of bone marrow was understood, not well known. And so Dr. Hoffman, as a dad, started to call around and say, what do you know about this? What can we do? I'm a match, but maybe donating bone marrow to a child is difficult because of the genomic collision. And it turns out that there was a paper written in Seattle by a fabulous group of scientists led by Jakob Dieg that basically said, here's the 18-year history on treating parent-to-child cases, and we've had fabulous results. And it's better than what the NIH will tell you, and it's better than what most academic medical centers. So here's a doc at Stanford, a world expert, discovering, unearthing this piece of information that would ultimately save his kid's life. Now, that crystallizes the problem. You've got all this information. I liked what we just heard. It's an information problem. You've got all this information. You've got these people who are making scientific breakthroughs every day. But the speed at which we share that information, learn between doctors, is glacially slow. And when you are the patient, that is a scary proposition. And so we said with Grand Rounds, we're going to make what Dr. Hoffman did for Grady, we're going to make that available for everybody. Fast forward 4 or 5 years, now we're covering more than 3 million people. We're doing that around the country and delivering on experiences like that every single day.
Well, what you're doing with physicians, you're looking at the data, you're analyzing the data, and you're really trying to rate them, evaluate them, get their reputation. In fact, you've been doing that with Reputation.com, which you started in 2006.
Yeah.
So you're familiar with taking this data and making sense of it. So you started Reputation.com in 2006.
Yep.
You've raised $100 million for Grand Rounds.
Yeah.
Clearly, you don't become successful if you don't have a number of failures to get here.
Sure.
So for those entrepreneurs here who want to feel that you're real, that you're human, and you make mistakes, because they will, just give us a sense of what were some of the failures and challenges at Reputation.com, maybe early in Grand Rounds, that you learned from.
Yeah, so Reputation.com, for people who don't know, was a business that we built to try to understand your online persona and to make it safe in a world that was increasingly about how I value you via data that I can collect on you online. I could form a snap judgment based on what I read on your LinkedIn, photos I see of you on the internet, and this is still true today. This is how we hire people. This is how we date people or not. This is how we marry people or divorce them. And so that was the idea. How could we quantify and scale that? I think that the through line, we made similar mistakes in both of those places. And I've learned to just be a touch faster, I think, at Grand Rounds, which is when you see the market moving in a direction where they will pay for a solution, follow that. And I think that's incredibly important for healthcare entrepreneurs, that there is a lot of money out there to get behind your businesses. I just heard about great blood pressure monitoring technology behind stage. I was talking to Ian here in the front. There's great funds available to support these technologies. But if you have a solution that is not costing somebody something somewhere in the world, that's not a solution that you're likely to get traction on, even if you have personal conviction around it. And it may sound incredibly simple, but with both Reputation and Grand Rounds, we had to learn through that moment. And very specifically, the moment we learned at Grand Rounds, which I hope will be helpful for all of you, is we started as a consumer company. Basic lesson of healthcare, at least in the United States. Consumers don't buy healthcare. We grow up in a system where somebody else.
Grand Rounds you started it.
Grand Rounds. So,
right.
so we're accustomed to our employers, maybe the government, but it's always somebody else who is underwriting most of the dollars in healthcare. And so we started as a consumer company. We offered this idea that you could consult with an amazing doctor at the Mayo Clinic or Harvard or wherever, and it was like silence on the initial model. We could not get consumer distribution no matter the price point.
What
so we
is
pivoted
silence?
to the enterprise.
What wasn't enough?
Wow, so man, I think we did 100 paid consumer cases. We started the company in 2012, and so that's what we were muscling through at the time. I mean, it was complete.
So in a month, in a year?
In a year.
Oh, okay.
Complete, and like 2 of those were my mom, right? So it was a complete abysmal failure. I mean, think about the value proposition.
Yeah.
Any disease, you've been diagnosed with stage 3, colon cancer, you can work with the team at MD Anderson and Sloan Kettering concurrently. You can get them to review your labs and your MRIs and your genomics and all this stuff, and you can get a kind of top shelf diagnostic and therapeutic plan, and people wouldn't pay for it.
Was it the way you marketed it? And if you were advising a startup here, and some of them are probably looking at B2C models, would you say give it 6 months? If you don't reach a certain point, then forget about it? Because there's a lot of learning.
I think the distribution vehicle was wrong, and I think that we had to discover and really study what the ROI model was. So it turns out that 67% of the time, the experts at Grand Rounds recommend a different diagnosis or treatment. As a patient, that should scare the bejesus out of you.
Yeah.
And that of that 67%, oftentimes they were recommending procedures and surgeries that wouldn't work. And so our experts would say, don't do that. It's actually going to make you feel worse. It's not going to cure the underlying problem. And so 40% of the time we were canceling or replacing surgeries or therapies with more efficient, lower cost. So one day, and it was literally in an office of our angel down in Palo Alto, we just crunched the math of what that would actually look like. And from there was born this ROI model that we then took to enterprises. 2 years later, we were covering all of the employees at Comcast, Target, and Costco. Those were our first 3 major customers, and now we have...
it just happened quickly.
Yeah, now we have over 200 companies that look kind of like that.
And about 3 million
over 3 million covered lives.
So was it the pricing? I know it's $600 for a doctor referral, $7,500 for a 7-second opinion. Was it the pricing?
I think the pricing doesn't help, but we experimented with that a lot. And we've gotten into a kind of an interesting different model now. So if you go to UCSF or the Hospital for Special Surgery or Boston Children's Hospital or Mass General Hospital in Boston, you go to their website and you're looking for an expert as a patient and you want to consult with that doctor, you can pay with a credit card and you're now running on Grand Rounds infrastructure. So what we figured out was the way to get to the consumer was to effectively license that technology platform, our 50-state compliance, all of our medical records technology, the matching technology on expertise, and now you can actually see it through those platforms, but we really don't market the direct-to-consumer opportunity through grandrounds.com.
Okay, I want to talk about we're already talking about the early days, but more about the other side of your market, which the physicians are. So, and I also want to mention that we do have microphones here, so, and I want to make this interactive, so if you have a question, we are going to open it up when we have 5 minutes left or 10 minutes left. So if you have a question, please line up, and you can ask Owen directly. So for the physician side, what did you do? It's hard to build up physicians. It's hard to get their attention. They're busy. How did you manage to find them, attract them, and what are some of the wacky things you did to build up that pool?
Yeah. So I would similar idea. What's the problem you can solve? We've probably all heard the idea of selling vitamins versus selling painkillers. The vitamins. Sounds like a good idea. Sounds like you can be taking something that will prevent pain later, but really what flies off the shelves are the painkillers. And for physicians, they have major pain around this topic. And their pain is, let's say you're a world expert in the treatment of brain tumors, right? Your desk every single day is going to be crowded with FedEx boxes containing CDs, unfortunately this is still how we do it, CDs, DVDs, that have MRIs from people around the world asking for your opinion. And you as a doctor, and you as a good person, want to do that, but there are a few problems. You're not paid for it, so this is time that you have to just kind of donate. You are actually probably violating your medical malpractice insurance if you respond, because more likely than not, the patient is actually outside of your state, which means your medical licensure doesn't cover it. And you're also therefore violating the compliance rules of your hospital. So you're taking a lot of risks responding, and yet these experts do this. So when we went to them and said, we're going to pay you an honorarium for doing this work. By the way, we're going to pay you in like 3 days, not like the insurance company that pays you in 45 to 60 days. So you're going to get the money fast. It's going to be secure. You can do it on your iPad from home. You don't have to dial into some awful VPN. You don't have to use Epic ever. And we will present the patient in a way that allows you to do extraordinary work, life-changing work in 30 to 45 minutes. You get paid. And it's clinically interesting. So if you're take that same doctor who studies glioblastoma multiforme, awful brain tumors, right? Fortunately, they're rare. And if you are a doc who is expert in that, you want to see the patients who have that specific situation for which you were put on the earth to cure. And so you create a great two-sided network. And so over time, as the company scaled, you have to load balance the network, make sure you have enough expertise to align with the patients.
So great value proposition it sounds like a really easy value proposition for them to embrace.
Yeah.
Economically, but and also because they feel compelled to practice their trade and treat these folks with those conditions, and
right.
They want to find them too. So your service ranks and evaluates these physicians. And so in the beginning, I'm sure you looked at where they went to medical school, how often they practiced, and things up with the mic, how often they conducted a procedure. What were some of the minimal viable product traits that you looked at to start ranking? And then this is sort of more Moneyball. What were some of the traits you looked at and discovered that were sort of, aha, doctors that do X are actually really good at doing Y?
This is literally the $3 trillion question, what you just described. Because we think of doctors as being major kind of consumers of the economic dollars associated with healthcare, but the reality is they are paid less than 20% of the overall healthcare picture in the United States. But they drive the remaining 80%. So they are responsible for recommending devices or not. They are responsible for recommending surgeries or not, hospitalizations or not, pharmacy, you get it, right? So the match that you make with your doctor as a patient and to the person who is underwriting care, who's paying for your care, that is the most important, most profound moment in the entire journey, is that match. And so for a while it was easy for us. When it was just people in the Bay Area and they wanted access to expertise, we could kind of figure it out in a lot of the ways you just described. But it was clear to us starting in about 2013 that we needed a way to scale this to understand the practice patterns, the expertise, and the outcomes of all 770,000 doctors that practice in the United States, which is a really hard problem. And we can talk about it as much or as little as you want today, but what I'll tell you is that the whole point most of those $100 million I talked about, we pour into just the study of this one topic. That if you come to us as a patient and you're on an insurance network in a certain location and you're looking for an answer on a specific clinical thing, that we are going to match you with somebody who's going to be exceptional. That they will have demonstrated outcomes, that they will have demonstrated clinical judgment, that they will be well-trained, well-positioned to do that. To just give you a sense of the problem in the United States, if you just look at most doctor profile pages, 60 to 70% of the clinical interest that a doctor will describe, they actually haven't treated a patient effectively for that condition in the last few years. Now this makes sense. You come out of residency and you're an orthopedist and you say, I treat hands, ankles, backs, knees, hips, da-da-da. Well, the reality is most of the practice may now be built around you treating knees. And not even total reconstruction of the knee and not knee replacement, but arthroscopic meniscal repair. And for that, you as a doctor are excellent. And you should be matched with patients who need that. But you should not be matched with patients who need foot and ankle repair, even though at some point in your time you trained that. And if you're a patient, you are massively outgunned in that fight. You don't know that. And the doctor that was referring you probably knows enough doctors to know that this is an orthopedist, but they're not likely to know that that guy or gal is super expert in that narrow area of knee surgery. Because for a primary care doctor to maintain that graph of doctors in their head is impossible. You'd have to know the names of 1,000 doctors, and then you'd have to graph on top of it, where are they located? And are they taking new patients? And do they accept the insurance that the patient has? That's an impossible information problem.
So you're looking at the biographical data that could be outdated, but you also match it with the insurance claims to see what these doctors are actually doing.
Right, exactly. So how do we know that that's true, what I just said? Well, we know it because we study, what are we up to? 7.5 billion commercial claims that we're processing annually now. So we see every single doctor in evidence every single year. We also collect the medical records of our patients. We also survey our patients. We also survey other doctors for their experiences with doctors. And then we look at a bunch of really interesting stuff around patient loyalty, turnover rates, clinical experience, hospital readmissions, infections, blood loss, so on and so forth, to get a really crisp picture of, given a specific need, is that doctor going to deliver? And then recently, the cool thing, and this is the big area of thrust for us now, is where's the patient? So how do we model the patient to understand, this doctor may be world-class at shoulders, but really world-class for NFL players. That's great for those people, but not great for the 80-year-old who plays golf once a year, right? So making that matching really work is critical.
So I looked at this study. It was several years old, but they were trying to identify traits of top clinicians, which you're trying to do. And in this study, they found that the top clinicians had following traits: intrinsic motivation, humility, engagement, and adaptability. Those are more qualitative.
You want to know the other one that they just discovered? That they're
reflective
that
practice.
they're women.
And they're women.
That was the other big one.
Okay, well that's easy.
Yeah, well.
To find out. So, it used to be easy. Anyway, how does big data surface up those qualities? I know you have 80 physicians that actually also overlook and view the data. Yeah. But
so our approach to data science is very multidisciplinary. You referred to this. This is where I came from. This is what I did at PayPal and eBay. Before it was even cool to be a data scientist, this is what we were doing. And I worked with a bunch of people who have gone on to be truly titans in the field. And so we see this as a data science problem, but it is a hard data science problem in the sense that it's not simply about forming a pattern that you can have an incredibly high confidence interval time and time again. You have to develop models that will work kind of subspecialty at a time. I would agree that all of those qualitative things that you said are true. Although we don't do the psychographic testing on physicians to figure that out prior to the fact. So basically we look at the clinical outcomes, including some of the stuff I talked to you about, and then we map back to make sure that the patient has a terrific experience. Because one of the things that we discovered is you can be technically excellent as a surgeon, but if you're a complete asshole, forgive me for saying it that way, it doesn't matter because people aren't going to stick with you and they're not going to follow your recommendations on follow-up and physical therapy and whatever. So it's actually incredibly important that that match exists in a way that's going to work for the patient. The one that you didn't mention that we hear all the time, and I think is present in every survey, is just, do doctors listen?
Yeah.
Right? Do they listen, and do patients feel understood? It's amazing, the breakthrough. Patients, and I don't know if this has been tested in a double-blind placebo kind of thing, but just physicians who show more curiosity and listen and seek to meet the patient where they are have stunningly better outcomes, which is incredible.
Well, let's switch gears. Let's talk a little bit about driving down costs, which is one of the things you want to do with your service, because as you and I talked before, when you get a second opinion, what did you say, 67%?
67%.
Yeah, right. So what they're saying is that if you don't get that second opinion, you may be undergoing procedures that you don't need to be undergoing. So, but the model, as you mentioned, was tough to get consumers to purchase this. The model selling to employers, we know that a Kaiser study was done that insurance premiums have gone up 50% since 2008. As an employer, I know insurance premiums benefits are expensive for our employees, and I know we need that in Silicon Valley to attract the best workers.
Yeah.
But how do you sell this additional benefit to employers, and so they understand that this is economically the thing they should do, because it's an expense, it's an added expense, right?
Yeah. So I would say we started the company to take care of patients because we had all had personal experiences with this. And when we get sick, we want access to experts. We want that doctor in the family to guide us through. But it wasn't going to work, it wasn't going to scale if we didn't find a way to make it tasteful, passable, saleable to the financial underwriters of this whole system. And so we go with a pretty straightforward proposition to employers and other buyers of benefits, and we say, listen, you want to do this. We usually have kind of lock-in that this is something that, all things equal, they would like to add. And then we say, and by the way, we're going to save you money, and if we don't, we'll make you whole on that. And it's actually pretty cool, because for those of you who know the employer space, what's tough is that the traditional ways of measuring reduction in spend are, I'm going to look at what's called the trend this year to next year, or this period to this period, and hard to ascribe the value or the savings to one specific vendor. We come in and we have the roster of the cases we did, and we said, here's where we increased the cost, here's where we lowered the cost, here's where we didn't change the cost, and we go case by case. So they can see on a claims basis the direct impact.
So can you, how are you lowering the cost? By how much?
Yeah, so I'll give you a basic example, right? I'll give you two. Sometimes we'll see a cancer patient that there's been a massive breakthrough pharmaceutically for a particular kind of marker within a particular kind of cancer patient, and the doc who's treating that patient isn't aware of the availability of that drug or that specific formulation. And the expert makes them aware of that. And that actually could have a life-saving effect on the patient, but also drive up the cost. And so we look at the total cost of that patient prior to us meeting them, and then post-engagement, and we look at the difference and we report that to the employer. Then there will be the time where somebody's recommended back surgery. If you know anything about back surgery, great area, by the way, if you're looking for a place to dip in. Back surgery, by and large, doesn't work. It doesn't actually deliver against the patient's expectation of reduced pain, increased mobility, and so on and so forth. And so we say, look, this spinal fusion isn't going to work. Let's replace this with something that'll actually make you more comfortable, more effective, and get you back to work. And that would be a net reduction of whatever. And so then when you tally all those up, what you find is that you actually net a cost savings.
Reducing unnecessary.
It's not just reducing unnecessary. It's also about switching to the most modern, effective therapy. One of the things that's horrifying is that there are doctors in the country who still practice open incision rotator cuff repair, although we've been using arthroscopic repairs in this country with far fewer infection rates, far higher patient satisfaction and outcomes after a year. And the reason they're still doing it is because that's what they were trained to do. And so if you were a patient who stumbled into that clinic and you happen to talk to the orthopedist who only knows how to do it that way, that's what you're going to get. And so replacing the therapy also is critical.
So again, if anyone has questions, we have mics over here. I want to talk about today. I mentioned that today that the House is voting on the Republican health plan, and Owen wanted to touch on that a little bit. So there was a report by the Heritage Foundation, it's a conservative think tank, that said that many provisions in the ACA were driving premiums higher. What provisions would you like to see that could help drive costs lower?
Yeah, so I'm kind of mixed opinions on this. Is the AHCA, the American, well, I don't even remember what it is. It's not the ACA anymore that they're debating. It's the AHCA, and the vote is supposed to be even happening as early as today, although it doesn't seem, as of what I was reading this morning, that they have the votes to get it done.
We'll keep you updated throughout the day.
I think, by the way, even if it passes the House, the likelihood that it passes the Senate without major changes is very, very low. But there's been a political promise made. I mean, it's crazy that we're even talking about this.
We won't talk about politics.
To me, the critical part that it seems to be under debate even at this hour is whether pre-existing conditions should be covered in any forward deployed version of Medicaid, Medicare. And for me, and I think as any American should really stand up and say that's got to be covered. That was one of the problems with the system before, because what you create policy for doesn't reduce the number of sick people in the United States. We're going to have to deliver as much care. It's just a question of who's picking up the tab and whether those patients will seek preventative care, so on and so forth. And so one idea that I think intersects with the commercial reality of a lot of entrepreneurs is if you're trying to sell to hospitals, you should want more coverage in the United States, because if that doesn't happen, hospitals are going to be seeing these same groups of people, but those people are not going to be able to pay for their care, which is going to leave the hospitals with a ton of bad debt, which they had in the 90s. And that bad debt is going to stifle their investment in innovation and science and research and a lot of other stuff. That's a terrifying outcome for all of us if that happens.
We have time for one question.
Good morning. Good morning. Hello. Hi. Good morning, Owen. How are you doing?
Hi.
Thanks for being here. I'm David. So I appreciate what you're doing. And as a person who is living with a person who's seen lots of doctors over lots of time and not got the results that we want, I can really appreciate what you're doing. So my question is two things. Hopefully it is helpful for everybody else here also who are entrepreneurs who want to get into the ecosystem. The question is two parts. One is there a way for other software providers to work with your system? And if so, which kind of partners are you looking for?
Yeah, absolutely. So this is actually perfect. I did not ask you to ask that question, but I'm so glad you did. So the thing that Grand Rounds has done really well is when people are dealing with complex disease or injury, we are the answer for reviewing that diagnosis, getting treatment, and matching with a great physician locally or remotely. But there are all sorts of other conditions that people are living with every single day that we don't have the answers to, but they get raised in our normal conversation. So we are actively looking for partners on behavioral health, on fertility, on GI conditions, on sleep conditions. So our goal is actually not to provide all the answers to the clinical questions, but simply be a place where a patient can trust that they will be steered to a really high quality resource, that their data will live on our platform, and that they will never be limited for the amount of time and the amount of experience they have. We think that's a better vision for the future. So I would love to meet people who are interested in helping us do that.
Okay, and those are companies you might want to partner with if, and this is the last question, given your experience as an entrepreneur, serial entrepreneur, starting companies, having a vision, given the landscape politically as also culturally, technologically, what kind of startup do you see, what kind of opportunities do you see for a startup? If you were talking to a number of startups, what would you start today? What would you advise them to do?
Yeah, I think there's a lot of interest. So there are a lot of people who are working on sensors and wearables in this audience. I would love to see somebody who's trying to be less about a wearable or a sensor and more about how do you commingle all that data and make it useful and make it shareable. I think there will be an enormous company that builds that idea. And then on the kind of a specific kind of commercial idea, one of the things back to what the GOP is likely to push through in some form is pushing responsibility for Medicaid back to the states. That is going to create 50 different Medicaid programs around the country, some of which will have very consumer-driven, highly commercial models. I think that's an enormous opportunity for you to step up and say, we're going to help people make sense of these decisions financially, clinically, so on and so forth. I actually think that's a net positive for entrepreneurs.
That's an excellent idea.
Yeah.
$100 billion going into the states for
Yeah,
those medical
exactly.
funds. So, Owen, thank you so much.
Yeah, you
That
got
was
it.
Great.
Thanks.